Today we're going to start the meeting off with three of the cornerstone institutions that have been on the front cutting edge of rural health care for quite a while and who seem to be reinventing themselves and energizing the Georgia State Office of Rural Health and the Healthcare Georgia Foundation and Augusta University, the Medical College of Georgia within it, has now created a new institution that is focused on rural health care. And as Professor Kahn says, we are having intense and urgent conversations. I see them. Dr. Burke from the Georgia State Senate will be here with us today to talk at lunch, and he and I were talking last night about many of the urgent conversations that are happening at every level: county commissioners, hospital authorities, development authorities, state senators, state representatives, technologists like Steve McGraw from Reach Health. We are all in this together, and the silos that we have seen and been in for a long time are coming down. And a gathering like this is an attempt to bring those silos down more rapidly, to have us collaborating more intensely. Of those three institutions I mentioned, we're going to take them in order, and so that you remain focused, I'll introduce each of them as we go. Dr. Gary Nelson has been the head executive leader of the Healthcare Georgia Foundation. Gary, are you here? We're going to start with you if you are. Yeah, there you are. Come on up, and I'll say a few words about the Healthcare Georgia Foundation. You probably, if you're involved in healthcare to any extent, have already heard of the Healthcare Georgia Foundation. They are a well-endowed, well-governed, and well-managed organization here in Georgia. They're statewide. They are a private independent foundation, and their goal is to advance the health of all of Georgia and to expand access to affordable quality health care for underserved individuals and communities. And Georgia, like most states, has access issues. The foundation seeks to accomplish this mission through strategic grant making. And Tammy Mims, the CEO down at Jeff Davis Hospital, and I were talking over coffee this morning about a grant that they're working on. Tammy will be on one of our panels. Programs, they also work on programs that improve health and health care among underserved individuals in Georgia, and initiatives of the foundation include, importantly, the To Georgia initiative, which Dr. Nelson will tell you more about, which seeks to address the growing disparities in health and health care between Georgia's urban areas and Georgia, the rural part of the state. So without further ado, Dr. Nelson, give us a little, we're giving you each 10 minutes. I hope that'll be enough. And if you do it in 5, then you can take questions. But tell us a little bit about what is keeping you up at night and what's going on with you.
Great. Thank you, Bill. First of all, I must begin by thanking you, the Bowling Company, Mason, and your team for continuing to shine the spotlight on rural health issues. We've had the opportunity to work with the Bowling Company now over the last couple of years, and a couple of products have come out of that. Obviously, we saw each other not more than a month ago focusing on telehealth, but we've also worked with you in conducting a capital needs survey that I hope Bill and others will be talking about shortly. But this time last year, I was participating in the summit, and I was describing some of the early work of the To Georgia initiative, and an initiative that, a term that's borrowed from a comment a legislator made back in the 1990s about the stark differences in the economic vitality between urban and rural communities in our state. And so I chose to use that term to describe what I thought, and later I think is proven to be true, the significant disparities in health and healthcare between urban and rural parts of our state. The 109 counties in our state are rural as defined by 35,000 people or less in those counties. And just simply one statistic, if you look at the county health rankings that are produced every year, of the 159 counties in our state, overwhelmingly, the bottom 34 on health outcomes, including mortality, are rural counties. 9 of the bottom 10 counties are rural. They also have the highest poverty rates. So there's a clustering of conditions that perpetuate and will institutionalize, if we're not careful, some long-term outcomes that we'd like to reverse. I shared with you at that time, we had commissioned 12 papers. We were conducting 2 statewide public opinion polls on what Georgians think about the concerns or issues related to rural health. We've, I think, interestingly, reached out to the business community and local elected officials, and we did a number of listening tours with county commissioners, chambers of commerce, mayors throughout rural Georgia, and heard from them their perspective on the rural health crisis. We engaged the National Rural Health Association and HRSA and a number of other organizations, including CDC, to get their guidance about what we should be doing. Then we began the process of thinking about, okay, what does this mean in terms of grant making? And so we started doing grant making last year, $2 million, by the way, and has already been awarded to a number of partner organizations around our state to work with communities most affected, deeply affected by the changing healthcare landscape in rural Georgia. We did a number of listening tours this past fall after we talked at this summit, and heard a lot about the needs and the problems and the opportunities. And based upon that input, we designed and released, I think, an innovative, maybe disruptive RFP that was released in January. Not sure who would respond because it's really messy. We gave communities maximum flexibility and choice in how they may go about addressing the changing landscape in their communities. What's happening when those 9 or 10 hospitals leave or cut back on services? What's happening when you've got 80 or more rural counties with designated workforce shortages? So, not knowing what would happen, on March 3rd, the applications came in, and we surprisingly had 34 communities, collaboratives, partnerships around the state, coming from these rural communities, again, 35,000 population or less counties, that have submitted applications. My colleagues, the staff at the foundation, and I are reviewing them now. Next week, we'll bring in our external review committee and make some determination or selection. And our intent is to fund up to 20 rural communities in this state. Not for tomorrow and just tomorrow, but for long-term funding. The first year will be some planning, particularly in terms of a population health improvement plan. But more importantly, how they will go about for the next 4 to 5 years with our funding, continue to transform their local communities in terms of health and healthcare. This is an initiative, the 2 Georgia Initiative is one that's accelerating impact from my perspective. It's accelerating how we deliver impact and how we measure it. What I'm excited about is the fact that the opportunity to address health equity, the inequalities in health that exist in rural Georgia, the opportunity to address disparities in health care, the opportunity to build healthier communities, the opportunity, and perhaps the most unique aspect of this initiative, is the opportunity to address the social determinants of health. Poverty, transportation, housing, unemployment, jobs, and literacy. As a health funder who needs to protect our funding for health purposes, I think we've pushed ourselves to think about what it means and what it would look like if we truly address the underlying determinants of bad health outcomes. So we're going to have to deal with something we've never done before. And we're going to take a page out of what we learned from all those 20 communities and continue to do that work. But that's, in sum, what we've done. The most recent funding announcement was to Emory University. They were selected as our overall evaluator of the initiative. The Emory Prevention Research Center. It was a very competitive application, and we assume that the 20 communities that we fund will also be very competitive. By the way, the communities that did apply, interesting mix of lead organizations. 4 of them came from hospitals with the lead. 3 or 4 of them represented federally qualified health centers. 2 school systems applied. 1 chamber of commerce. 1 family connection partnership, if you know that entity within county infrastructure. So we've got a mixture, a hybrid, if you will, of a variety of organizations that are pursuing this funding. So I'll stop there. Thank you for attending this important event. And again, a special thanks to Bowling & Company for what they've done.
Thank you, Gary. Stay close, because if we all do as well as you and stay on time, we're going to let them ask y'all a few questions.
Dr. Canto, are you and Catherine here? Ask you to come on up. I've been very, thank you so much, Gary. Just please keep your seat. I've been very fortunate in my career and in my life, really, to always had the opportunity to meet and work with people who have taken me by the scruff of the neck and helped me learn a few things and improve. And I have to put Dr. Canto at the top of the list. In 2000, I went to Augusta to be the general counsel of the MCG Health Inc., which was the clinical delivery system. Dr. Canto at the time was the medical director at the Children's Hospital, and as much, perhaps more than anybody, he taught an old country lawyer like me about what it was to try to deliver healthcare services in a major and important public health sciences university. And he has just continued to be an amazing resource for the state of Georgia. There's probably not of the 159 counties, many of the projects he's done over the years, there's probably not a single one of them that hasn't been impacted, Bill, in an important and a good way from your efforts. So just thank you personally for all that you've done. And he doesn't pay me, for this. It's just true. He is, if anybody is legendary, it's Bill Canto. And he's now got Catherine Clary to help him with Augusta University's exciting new program, the Center for Rural Health Support and Study. This is a brand new initiative of Augusta University and the Medical College of Georgia. It's established just last year. Some of the research they did was supported and helped out by Gary's group. The goal of their center is to make rural hospital stability an institutional priority of the Augusta University and AU Health through the statewide coordination of clinical and educational outreach, as well as multidisciplinary research, which is very appropriate for an institution of research and higher learning. The center works with hospitals as a resource for the education, training, consulting, and sharing of best practices. Bill's group, and Bill personally, has worked with several of the rural hospitals that I have been fortunate to work with, and they seem to be everywhere. I don't know if he ever goes home, but everywhere I go, seems like he's just there, or he's on his way, or he's there. The center also advocates for policy changes at the local and state level that will benefit rural hospitals. So watch out, Dr. Burke. You may want to try to stay on the other side of the room from this guy. So Bill, would you and Catherine please come up and take a seat and grab a microphone and tell us a little bit about what y'all have got going on.
Okay, well, Bill, first off, thank you very much, and that was over the top, and my mother would greatly appreciate it. But you didn't mention the one thing that I think is important that I was a part of, because I think it is a model that we can use in taking care of patients in rural communities, and that is the perinatal regionalization program that was established in this state. And that's actually what I came here first to do. And at that particular time, the infant mortality rate was 20 per 1,000 live births. Dr. Burke was in high school, I think, at that time. So he can't take responsibility or credit, I might add. But in all seriousness, we developed, and it was not me, it was a whole lot of people working together, a perinatal regionalization program that made sure that any sick baby in the state could get to the level of care that they needed, and the mother could as well. And that has been instrumental in reducing our infant mortality rate and our maternal morbidity and mortality rate. And it is something that everybody who participated in that should take a great deal of credit and pride in what was accomplished. I did the calculations one time, and there's basically 1,000 babies who lived to their first year of life who weren't living before. So it's a huge success, but it is also a model of what we can do in terms of providing health care to the rural populations. And I'm sorry, he got me started on that, and I had to get on my soapbox and evangelize for just a minute to remind people of successes that we have had in this state and the fact that we have to remember those successes and emulate them when possible. Paid political announcement. Thank you very much for listening. Okay. In 2015, Dr. Brooks Keel, a native of Georgia, was named president of Augusta University. We are Augusta University. We will stay Augusta University. You don't need to worry about changing it anymore. We are Augusta University. That battle is fought, won, and over. Anyway, Dr. Keel realized that AU was the only state medical school. And as a state medical school and institution, And as an academic center, or excuse me, a medical center within the state, he felt that there was an obligation for us to be involved in healthcare, and he felt like we needed to focus on rural healthcare. And at the time, we wanted to focus on rural hospitals because they were so essential to the provision of healthcare in a rural community. So Dr. Keel appointed a task force to look into this, and a number of folks here in this room actually testified, wrong word, presented, maybe we didn't swear them in, okay. But they did come and present to us and give us some insight into what was happening with rural hospitals and rural health care. As a result of that task force work, a report was issued. It's available, it's out there now, if anybody would like copies of it. If you have trouble sleeping at night, I would suggest you start reading. About page 10, I think you'll be okay. But all kidding aside, the task force did issue a report, and what came out of the report was a recommendation for a Center for Rural Health Support and Study. Notice the study piece, because we know there's not all the answers yet, okay? And we thought as an academic institution, we could be helpful in addressing some of those questions. The center has been initiated, thank you, Gary, and Ms. Catherine Clary, who's going to talk about it and share with you what we're going to try and do with the center, is the new director. She was appointed in February, hit the ground running, and she will be happy to tell you more about it later, but she wants to tell everybody a little bit about what we're trying to do and why we think this is a unique organization. Catherine?
I have slides. I thought it was a little more formal than this, but I'm glad it's not. So I just wanted to go over what our goal is, which I think this is probably the goal of everybody in this room. But we want to provide the expertise and resources that we have at Augusta University to ensure that rural residents receive the same level of care with patient safety and quality that anybody living near a tertiary center would receive. And then just a little bit about our center. We are trying to work to be a resource for other institutions and other organizations throughout Georgia. As Dr. Canto was saying, we are trying to use a multidisciplinary, interdisciplinary approach. As Bill was saying earlier, that our rural groups have been in silos. Augusta University, just like a lot of big organizations, has been working in silos. So the nursing school may not know what the medical school is doing, may not know what the business school is doing. So my role as director, I don't have a clinical background, but my role is to try to network all of these people together to get them to work towards the same goal. As he was saying also, we're studying to understand what the issues are. And then we're also working again with allied health and nursing to develop curricula to help students go back out to the rural areas. We also, our surgery department is looking into a general surgery rotation out in some of the rural communities. So we, through that, we're also identifying and advancing necessary changes. We work with our government affairs people to find out what's coming up, what we need to anticipate for, not that we can, read the tea leaves, but we try to know what to expect. And then Dr. Canto has been very strong in building models of clinical integration. So we're trying to do that throughout the state, and then also working with telemedicine. So one of the things that we want to do is keep the patient as close to home as possible. And whether that's through swing beds or telemedicine, shared services, we know that it's best for the patient for them to be closer to home, and then also helps the rural communities. So that's something that we really want to try to come up with different ideas to get that patient back in their community. So I think that's pretty much what I can talk later about the different projects that we're working on, but those are just the goals that we have in moving forward. Thank you.
I think Bill's trying to avoid getting up here, but you're still fair game, Bill. Even though you're out there, we know where to find you. Well, our I guess one of our longest standing resources and one of our most powerful resources in the state is the government. And we are lucky to have with us today Lisa and her colleague from the State Office of Rural Health. And Lisa in particular, who I've worked with and know better, has been focused on rural hospitals, which is where we focus a lot of our effort. And her colleague also is involved, I think, across Nita, you're probably supporting Lisa, but working in other areas as well. It's a very powerful shop down in, been there twice, is it Cordele? And they are the friendliest people you'll ever meet. So, and smart, and they really know what they're doing. So, what the State Office of Rural Health does is manage state programs to develop regional quality health care systems to optimize health status and improve health outcomes in rural and underserved areas of Georgia. What that means is I can pick up the phone and say, hey, Lisa, I got a hospital that can't make payroll, or hey, Lisa, I got this going on, and they spring into action. This State Office of Rural Health strives to accomplish these goals by administering programs and develop financially viable, non-traditional regional health systems that meet the needs of the communities they serve. And Dr. Burke, if you and the Sons of the Gold Dome could just give them a little more money, I think they could just impact, never not ask for money. They also manage programs like the Hospital Services Program that provides technical assistance and resources to rural critical access hospitals. They got a great IT guy in that office that interfaces with those folks. The Rural Hospital Stabilization Committee pilot program is something that they have been engaged with and have worked. And I know Dr. Burke and Terry England, who will be our lunch program, will be talking some about what that program has accomplished and what the learnings that we have had from that and what's going to happen with that going forward. And then the Georgia Farm Worker Health Program, which works to improve the general health state of Georgia's migrant and seasonal farm workers and their families. So without further ado, Lisa, would you and Nita come up and tell us what y'all have going on?
I'd be glad to. And like you, I got excited and wanted to have a PowerPoint as well. But you know, I'm going to keep it simple to just talk about, first of all, what an exciting time to be in rural health. To sit and with this esteemed group as far as the resources that we are having available to work with and understand. I think when you talked about study, I think that is to understand what the needs are and meet those needs, that we don't show up with, here's a packet of things to do, this is what you should do, is understanding the need and listening to the voice of our customer. So at the State Office of Rural Health, I'm here on behalf of Patsy Welly, who is our Executive Director. I am the Director of Hospital Services, and Nita will speak in a little bit, is the Director of our State Office of Rural Health Programs. But we work with our mission statement. And I'm not going to read the whole thing, but there are some key words. The word empower communities, strengthen, build resources, and build partnerships. And I think that's the strongest part of what I do. I've been there, I'll be 2 years old in June. Come with a lot of energy and a lot of excitement, seeing a lot of faces that I'm starting to recognize, and that's wonderful because it puts us all on the same page. And when we think about if we're trying to build resources, we've built our program here at the State Office of Rural Health. We now have 11 employees. We're bigger than we've ever been in that respect. Not that we're needing to spend more of the government funding on employees. We're building programs that those employees help support. So we have 11 of us over 4 major programs. We have a $17.5 million budget, so thank you very much. The state of Georgia, I'm not from Georgia. I'm from rural Mississippi, rural Alabama, moved over to Georgia, lived a little bit in Kansas, lived a little bit in Tennessee. Air Force, too, in the little bit of the background. This is a state that the voice of rural is being heard, and that's exciting for us. So we are in 157 of our 159 states. You think, well, you're the state of rural health. How can you be? Our programs are far-reaching, and when we realize that the work we do in our larger urban counties affect the work that we can provide in our rural counties, that's where we are. So we are meeting the needs of Georgians in many ways. The Hospital Services Program is working specifically with hospitals. I work with federal grants out of HRSA to improve quality improvement, financial, operational. programs, and also have a small hospital rural improvement program that gives money directly to hospitals. We're proud of the fact that most of our money that we come from our federal standpoint goes directly back out to services to our hospital. We do not spend those on internal resources. The state has been generous to give us the resources to pay our staff. So we do have those programs. I assumed the role of the Rural Stabilization Pilot and Phase 2 programs starting in January. We transitioned. Charles Owens had been leading those programs, and now I'm the director of those programs, managing the work that they're doing. Exciting times of trying to structure solutions. And a lot to be learned from that, a lot more data, dig, study. Those things are needed in those programs. We also have David Glass, who is over our PCO program, so he is primary care. Your health provider shortage area designations comes out of our office through J1 Visa, trying to put providers into the rural communities. Those resources come out of our office. Some FQHC money comes out of our office. And then again, you generously talked about our farm worker program, which we are proud of, that we have those resources in which to meet the needs of that specific population. I'll turn it over to Nita to talk a little bit more about the state office programs and her work, particularly with some transitional work that we have.
Thank you. Thank you very much. I am Nita Ham. I'm the director of the SOAR program, so I'm the fourth director in the state office there. So, and it's, as you said, it's a great group. We have a wonderful group of people, and I'm very blessed to be the program manager for some really fun and eclectic grant projects. So I really have kind of three buckets under my section. One is I do manage the HRSA SOAR grant. DCH and the SOAR office is the designated recipient of that particular HRSA grant, and that is a match grant. So for every $1 of federal money, we match it with $3 of state money, and we have a lot of very supportive projects that are done underneath that particular in that particular bucket. The second bucket that I manage is the legislatively directed projects. So we have a handful of projects that are ongoing that were legislatively directed several years ago, and they continue. So I manage those projects, and then after every session is over, we anxiously await to see if we have new projects that we're going to be managing. Some of them are ongoing, and some of them are a one and done. It may be funding for a particular project for 1 year, but I manage those. And then the third bucket I have are sort of state-specific projects. And this is my favorite area because we really have a lot of creativity in our projects and our programs in that particular bucket. So one project that we have offer pretty once or twice a year are network grants, and I really love those because we put out a grant that's open for competitive solicitation. So once those open up, our network grant actually requires that we have at least 2 communities that partner together for a project. So those communities look at their own needs and they choose a project that addresses their needs, and then they apply for the grant. And I always sit on the review team for those grants when they come in, and it's so awesome to look at how these communities pull together and the types of projects that they choose to address the needs within their own communities. And the partnerships that I see formed through these grant projects is really awesome too. So, but one of the areas that I wanted to sort of talk about here today is some really innovative and creative projects that we have going on that have kind of resulted as a fallout of all of the hospital closures and the rural hospital stabilization project that we have. So when hospitals close or rural hospitals close or they begin reducing their service lines and the specialists pack up and go back to the big cities and the primary care providers leave town, one of the players that's always left on the field is emergency medical services there in that community. And so the reduction of service lines and closures of hospitals has impacted EMS also. But on a national level, this is a problem across the country, and on a national level, lots of folks have been looking at EMS to see how could they expand their services or what kind of innovative and creative projects could they become involved with to support their communities, especially in making connections for those patients whose primary care physicians have left town. So we really have got a wonderful a list of programs that we are working with EMS on to look at expanding their services and pulling them into projects and making connections with them that they've not made before. Traditionally, EMS responds to an emergency and then takes a patient to a hospital. But now we're looking at some of the EMS services in Georgia as well as across the state are interested in sort of developing non-emergency service lines. You may have heard of programs like community paramedicine or mobile integrated healthcare, and this is where EMS services are choosing to sort of function as an extension of primary care, where traditionally they've always functioned as an extension of the emergency department. So we have a lot of really good programs going on. One of the things our projects have taught us is maybe what doesn't work. So we're beginning to learn how EMS can be integrated into the communities. We're connecting them with partners like FQHCs and rural health clinics and behavioral health facilities. Partnerships that are now forming that had not existed before because there's really never been a reason for that. But we are really proud of those, and fortunately for me, I've got an extensive background in EMS, so I speak the language, and it's easy for me and a lot of fun too to help put these projects together and work with these communities to look at some really creative and innovative ways to address these gaps that are being created because of all of the challenges that we're having in rural health care. So that's me, and thank you again for allowing us to be here. I'll be around all day, so if anybody's interested in chatting or wants to pitch out some ideas or tell me something interesting going on in your community, I'd love to hear it.
Thank you so much, Nita. We do. You all did great. Big hand for our speakers. Despite Dr. Canto's paid political announcement, we still have time for questions. So please, and before we take questions, I did want to say Dr. Nelson had mentioned the capital needs survey that our company performed and that the Healthcare Georgia Foundation funded. We have these little handout cards. We'll put them on your chairs, or you can pick up one at the table. It gives you a link so that you can go and have the entire database. It's nearly 150 locations, 120 plus providers from all over the state. Tammy Mims from Jeff Davis was one of our many hospitals that responded. Gives you a really solid snapshot of what the financial picture is right now for rural providers all around the state. And thank you for funding that, Dr. Nelson. So questions for any of our audience? I'll start off with one. I wanted to ask Dr. Nelson, what are you going to do with this cat? What is your board? Why was your board interested in knowing having that survey done?
Sure. It's clearly more than just simply understanding the need and the financial status of hospitals, FQHCs, rural clinics, and the like. The program that I described to you is fully funded by the required 5% of our endowment. 5%. My interest is in understanding what we can do with the other 95%. And that translates into, for the first time, the foundation is thinking about and trying to figure out how best to do whether it's loans, whether it's credit, and other kinds of investment strategies that build on top of grants. So we do our work, that's our area of expertise, and that's our primary way of delivering income. But for us, that capital needs survey informs the needs and the potential challenges we might have if we think about doing loans and reduce hospitals throughout those areas.
And that low-interest loan may sound like, what's the big deal? These are $20 million a year operations, but you'd be shocked at how many hospitals have 20 days cash on hand and they have hit a little bump, and that bump for them is maybe the end of the line. And having access, and often commercial lenders and other lenders and sometimes county commissioners say, we've already given you what we can give you. So that would be, if that program gets off the ground, a great new tool for the state. I'll bring, if y'all will use your microphone, I'll bring this microphone out so if you have a question, you can be heard. Yes?
How do you see electronic health records and standardization of data flow playing into improving the quality of rural health care delivery?
Are y'all hearing that? Did you get that? Who do you want to direct it to anyone? Go ahead.
I was going to say, well, I'll take the bait on it, actually. I think when you look at particularly the work that we're doing in stabilization and a lot of the work that we're doing as a group, when you think about the projects that we have, having accessibility and transparency of data is very important. You have to start with knowledge. And so a lot of that, when you think about what data gives us and you think big data and those pieces of it, it's the integration of multiple sources of data pulled together for decision making. So I think on one level, that's it. For clinical integration, you can't beat it. When it comes to what you need to support rural health care, I think what you all said as far as one of your goals was to maintain people close to their home. Through telemedicine and those works, we have to have integrated healthcare delivery, and to be able to share that through either an exchange or where information talks to each other and those sorts of things is imperative. Getting connectivity so that they can do that from the alternate sites that we may be doing in some of our EMS programs. Care coordination, sometimes we have a lot of fragmentation in healthcare. Anything that we can do to pull that together. So I think there needs to be even more strategies in Georgia to try to shore up the ability for us to share data.
Great question, great answer. I saw a hand up over here. You, Doctor?
Yeah, I want us to imagine a world where the rural hospitals are all doing fine. And think about Georgia and say every one of them are financially stable. I'm fairly comfortable the healthcare outcomes that you mentioned, Dr. Nelson, where we rank nationally probably wouldn't change a whole lot. And so I want you to expound on what you feel like communities need to get more help. Because I am a champion for what we need to do for rural hospitals. I mean, it's critical. But I'm also, as a physician, very interested in the healthcare outcomes of our citizens. And we got to have one, but I'm not sure that fixes the problem. So I just wanted you to talk about that a minute.
Well, I perhaps naively so, but as an evaluator and as someone who's invested previously in these kinds of programs, I do have confidence that we will get some health outcomes. And the reason why is we're going to stay in it for the long term. Having said that, I think we need to sharpen our focus on measuring capacity. Back to the earlier question, I think data builds capacity, and capacity begets resources. And a critical gap in the rural community in terms of rural health care is the lack of resources. So I feel like we need to be measuring a variety of different outcomes along the way, including health outcomes, but also capacity. I lost my other thought about all of this. Resources for data. Oh, the other point, which we talked about last night, is something absolutely critical. There's no doubt in my mind that of these 20 communities, there will be some model and innovative practices that emerge that we will want to replicate. And so from that standpoint, I think there's some long-term returns on this investment.
What was said about the necessity of having data available and having data that's searchable available. Written records are not, well, wait a minute. Years ago, I used to do some research, and I used to have to go back through medical records. And at the time, they were written on Sanskrit and papyrus. But I can tell you it was awfully hard to get data out of there. And having an electronic record and having the data elements indicated as to what has to be completed gives you a database that can be used in multiple ways. And you can look not only at what is happening, but you can look at the outcomes of what is happening by doing it that way. It is a pain. It is painful. But it is a necessity if we're going to move forward, and particularly if we're going to be in the era of population health. And I want to emphasize that equally important will be the health information exchanges so that this data can be exchanged over multiple platforms so that you can look at this. And when we do move into, as everybody says we're going to, accountable care organizations and into population health, the care coordination will be critical, and you're not going to be able to do that without electronic data to be able to guide you in what you're accomplishing. And then the communication piece is also huge, and the ability to communicate across different platforms. So thank you. You covered it, but I just wanted to echo how important I think. And listen, I was chief medical officer of 2 institutions that put in electronic health record. I know the pain and suffering that goes with that. I still have the scars from that experience. I can't show you where they are, but I do have those scars.
Well, thank you